All right, let's dive into a pathogen that is, frankly, a clinical microbiologist's nightmare. We're talking about Nocardia Otitidiscaviarum. It's a real master of disguise. Now, this whole explainer is based on a Gemini deep search, and if you want to see the primary sources, they're all in the notebook linked below. So let's get right to it.
Okay, picture this because we've all been there. You've got an immunocompromised patient, they have a really nasty pneumonia, and they're just not getting better on your standard empiric antibiotics. The days are ticking by, and you start to wonder, what is going on? Are we dealing with something weird, or maybe something that's just naturally resistant to the drugs we're throwing at it?
Well, the answer to that question might just be Nocardia Otitidiscaviarum. I mean, this thing is the textbook definition of an opportunist. It's rare, yeah, but when it hits hard. And the real kicker, the thing that makes it so incredibly dangerous, is that it has this built-in intrinsic resistance profile. It's just naturally tough against some of our most common antibiotics. So, the big question is, how do we actually unmask this thing in the lab? It's not as simple as you'd think because this organism is both slow and incredibly stealthy. Let's walk through the investigation. So our first hint is going to come from right under the microscope. On your gram stain, you're looking for these really fine beaded branching filaments. That beaded look, kind of like a string of pearls, is pretty classic. But here's the absolute key differentiator. It's partially acid-fast, and you have to use a modified stain for this. A weak decolorizer like 1% sulfuric acid is what you need, not the strong stuff you'd use for TB. Getting that detail right is your first major step toward a presumptive ID. Now, when it comes to culture, it's a strict aerobe. But the single most important thing to know is that it grows painfully slow. I mean, we're talking 2, sometimes 3 weeks of incubation. This is where communication with the clinical team is so vital. If you even have a whiff of a suspicion of Nocardia, you have to call the lab and say, hey, hold those plates. Otherwise, they're going to get tossed long before these dry, chalky colonies ever show up. And yeah, you might even get that distinct moldy basement smell. And this really just shows you how far we've come. You know, back in the day, we were stuck with biochemical tests that took weeks and honestly weren't great for getting a species-level ID. But today, molecular is king. 16S rRNA sequencing is the gold standard. It gives you a definitive answer, no questions asked. And MALDI-TOF MS, what a game changer. It's taken the ID time from weeks down to literally minutes once you've got a colony. But here's the crux of the problem, right? Even with all our fancy modern tools, you still have this critical diagnostic gap. Because it grows so slowly, and you need that colony for molecular ID, you've got this period of days, maybe even weeks, where the clinical team is essentially flying blind. And the patient could be on an antibiotic that's doing absolutely nothing, which lets the infection just run wild. So we've established it's a pain to identify. Now let's switch gears and look at what it actually does to the patient. And I call it a master of disguise for a very good reason. It can look like a whole bunch of other more common diseases. The disease can show up in a few different ways. The most common is pulmonary nocardiosis, and on a chest scan, it can look exactly like TB or even lung cancer. Then there's the cutaneous form, where the bug gets in through a cut in the skin, maybe from gardening. But the one we all fear is disseminated nocardiosis. That's when it escapes the lungs, gets into the bloodstream, and can go just about anywhere. 44%. Just let that number sink in for a second. In almost half of all cases of disseminated disease, Nocardia makes a beeline for the central nervous system. This thing has a terrifying and often totally silent attraction to the brain. And that brings us to a massively important clinical question. Let's say you have a patient with confirmed pulmonary nocardiosis, but neurologically they seem totally fine. No headaches, no confusion, nothing. Do you still need to get a scan of their brain?
The answer is a resounding, unequivocal yes. Brain imaging is absolutely mandatory. The fact that they don't have symptoms means nothing. That patient could be walking around with a silent, growing brain abscess. Missing that is a catastrophic failure. It is a non-negotiable part of the workup, period.
Okay, this brings us to the main event, the real climax of the story. Trying to navigate the absolute gauntlet of antimicrobial resistance that comes with Nocardia Otitidiscaviarum. And the key words here are predictable and intrinsic. This isn't resistance that the bug just picks up along the way, nope. It's hardwired directly into its DNA. It's predictably dangerous, which means we know which drugs are going to fail before we even set up the susceptibility test. So let's actually look at the data here using the CLSI breakpoints. Up top, you've got our go-to drugs, trimethoprim, sulfamethoxazole, amikacin, and linazol. Look at that, 0% non-susceptible. These are our workhorses. But now, look down at the bottom, our common empiric drugs. Imipenem, 93% non-susceptible. Ceftriaxone, 100%. The MICs are just off the charts. And this bar chart just slams the point home. It takes us right back to that clinical trap we started with. The danger is just so painfully obvious. If you start a patient on empiric imipenem or ceftriaxone for what turns out to be this bug, you are using a drug that has virtually zero chance of working. And just a really quick but important note for our colleagues in Europe and other places that use EUCAST. Right now, EUCAST doesn't have its own specific breakpoints for Nocardia species, so the official guidance is to use the CLSI criteria. That way, we're all on the same page. So how do we actually treat this thing? It boils down to a three-pillar strategy. First, you hit it hard and you hit it fast. For severe disease, that means starting with at least 2 and ideally 3 active drugs. Second, you tailor the therapy. As soon as you get those AST results back, you de-escalate to the best, safest options. And third, and this is a big one, you have to prolong the treatment. This is a marathon, not a sprint. We're talking 6 to 12 months or even longer to make sure it doesn't come back. Looking at the guidelines, in the Netherlands, there's no specific SWAB guideline, so the advice is to follow the international consensus. For a severe infection in an adult, that usually means a cocktail of cotrimoxazole, amikacin, and linaclid. For kids, the principles are the same, combination therapy, mandatory CNS screening, but of course all the dosing is based on weight. Okay, let's bring it all home. Let's talk about how we can prevent these infections and go over the absolute must-know pearls to protect our vulnerable patients. Now, this is a super important point for infection control. Nocardia is an environmental bug. It lives in soil and dust. It is not spread from person to person. That means your patient does not need to be in isolation. Standard precautions are all you need. Prevention is all about education, telling your immunocompromised patients to wear gloves and masks when they're gardening. And in the hospital, it means having really tight dust control during any construction. All right, so if you take away nothing else from this, please remember these 4 things. 1, suspect it. Anytime you have an immunocompromised patient with pneumonia that's not getting better, it should be on your differential. 2, communicate. Call the lab. Tell them to hold those cultures. 3, image the brain. It's mandatory. No excuses. And 4, treat smart. Know that resistance profile and stay away from empiric carbapenems and third-gen cephalosporins. And that's our deep dive on Nocardia Otitidiscaviarum. I hope you found this useful. If you did, definitely subscribe for more explainers on these tricky bugs. You know, real-world experience is everything with an organism like this, so please share your own cases, your questions, your experiences in the comments below. Let's get a conversation going. Thanks for tuning in.